Welcome, Dr. Lolwa.
Thank you very much. Thank you. So the task, I guess I gave myself when planning this was to talk about the spectrum of liver lesions in Fontan-associated liver disease. I have no conflicts of interest. So the topics that I'll be covering today is to review the spectrum of lesions that occur in this patient population. I want to discuss the challenges that are associated with lesion characterization on imaging in patients that have undergone Fontan surgery, identify those at highest risk of developing HCC, and review the recommended screening modalities. But before I get to the liver aspect of it, I wanted to touch on the surgical aspect of Fontan. So just to quickly review, Fontan surgery is performed primarily in patients that have univentricular congenital heart disease. The result of the surgery is that you have systemic flow back to the pulmonary artery without a subpulmonic pump. It leads to chronic elevation in the CVP that is felt in the liver, hepatic congestion, and that's the primary issue that we see causing Fontan-associated liver disease. The classic Fontan was the original form of the surgery where the right atrium is directly connected to the pulmonary artery, as is the SVC. It was later developed into the intracardiac conduit, where a baffle or a conduit is placed within the right atrium, connecting the IVC and bringing back the blood flow back to the pulmonary artery. And then the latest iteration, and now kind of the standard Fontan, is the extracardiac conduit, where the conduit is now outside of the heart, bringing the blood flow back into the pulmonary artery. On a more microscopic level, the chronic CVP congestion leads to this passive congestion to the heart, impaired hepatic venous outflow. It leads to sinusoidal dilation, endothelial injury. In general, patients with Fontan surgery have reduced cardiac output. So you do see a reduced portal venous inflow into the heart. This leads to something called the hepatic artery buffer response, where there's a shift from a predominantly portal venous inflow into the liver to a hepatic arterial inflow into the liver. They do live generally at a lower oxygen saturation. You do have a chronic hypoxia in this patient population. And all of this is what leads to hepatic stellate activation and progressive development of fibrosis. The alterations in blood flow to the liver are kind of the initiating factor for the development of nodules in this patient population. The spectrum of lesions that can occur is wide. There are a couple that we generally think about frequently, like FNH-like lesions, and specifically we think about HCC in this patient population. But this was a very interesting case series where they wanted to perform an analysis of the molecular profile of patients that had undergone biopsy of their liver lesions with a history of Fontan surgery. And the array of within 5 patients, there was a wide variety of lesions. So they had a hepatic adenoma, a fibrolamellar carcinoma, trabecular HCC, an intrahepatic cholangiocarcinoma, and then an FNH or FNH-like lesion is what we typically call in this patient population. So although we generally like to think about certain lesions, we do have to keep an open mind to the variety of lesions that we see. Similarly, this was another study. It was retrospective. They reviewed the pathology of patients that had undergone biopsy of lesions that were found on imaging. And again, I mean, it's a very small slide, but you can see a wide variety of lesions. They had cholangiocarcinomas, they had vascular malformations, they had regenerative nodules. But what I found particularly interesting was there was one definitive PTLD in a patient that had a cardiac transplant in the past, and a possible PTLD. So again, just thinking about the fact that, we just need to keep an open mind to this patient population on what lesions we might be encountering. The predictors of liver nodules as a whole, not just malignant liver nodules. There was one study performed. It was a cross-sectional perspective study in 8 centers across Europe. They collected imaging data, cardiac data on these patients, and the primary outcome was to detect liver nodules on CT or MRI. On univariate analysis, they found that time since Fontan being over 10 years was one of the predictors of liver nodule formation, and protein losing enteropathy was the other predictor. But when they performed a multivariate logistic regression, the time since Fontan was the primary predictor of the development of liver nodules. The benign lesions, the most common we think about is the FNH-like lesion. Histologically, it looks like an FNH, but it is on a background of an abnormal liver. Based on imaging, we're looking at about 40 to 48% of patients with Fontan having FNH-like lesions, and they represent a hypervascular nodule that develop in response to the hemodynamic changes that we see in Fontan. And they do have a strong correlation with time since surgery. Hepatic adenomas are less common, or at least we think are less common. They do look similar to FNH-like lesions on imaging, so there may be some degree of underdiagnosis of hepatic adenomas, and there are reports of beta-catenin activation on patients that have had biopsies in the past. So again, there is some malignant potential for transformation there. The typical imaging features of benign lesions is that they tend to be small, well circumscribed. They are hyperattenuating on the arterial phase of imaging, and they are isoattenuating on delayed or portal venous imaging. There is a bit of a dilemma in this patient population, though, and that is that they not infrequently will have benign lesions that have features of malignant lesions. So they can be difficult to differentiate. They may end up needing biopsy when they are benign lesions. And one of the tools that does help differentiate them to some degree is hepatobiliary contrast. So this is imaging of a patient that was about 20 years post-Fontan. On the initial 2 images of the CT, you can see that there is hyperattenuation on the arterial phase, and there was washout on the delayed phase. So they ultimately ended up getting an MRI with hepatobiliary phase imaging, and what you can see is that on the transitional phases there is increased or high signal intensity, and then on the hepatobiliary phase there's also high signal intensity, and that indicates the presence of active hepatocytes and suggests a benign lesion. The problem with the issue with this with characterizing lesions in patients with Fontan is because there is an abnormal background liver. The thought is the congestion in the background liver, the alteration in blood supply to the liver becoming more, predominantly hepatic arterial, is what makes it hard and gives these benign lesions features of malignancy on imaging. This was an interesting retrospective study where they had radiologists review the imaging of patients that have a history of Fontan surgery. They had given them predetermined features and asked them to characterize lesions as typical or atypical. And of all the lesions they reviewed, they had 30 lesions that they described as atypical. And if you look at the graph there were 3 lesions that were biopsy proven FNH, and 12 lesions that were stable on imaging. They had not been biopsied, but were stable on imaging for over 24 months. And all of those lesions, I don't know if the pointer works. Yes, all of those lesions had washout on delayed imaging phases. So it just goes to show that this is a big dilemma. And there is definitely a lot of research going on in this field to try to help us characterize benign lesions appropriately and identify malignant lesions appropriately. When it comes to key imaging features of malignant lesions, we know from our cirrhosis patients, we have arterial phase enhancement, delayed washout, presence of a capsule. On hepatobiliary images, they have low signal intensity. And what you can see here in image D is that the lesion looks dark on imaging. And that indicates that there aren't active hepatocytes. It indicates the presence of malignant lesion. And when they resected the lesion, the patient was diagnosed with a trabecular HCC. So moving on to hepatocellular carcinoma, it was first described in Fontan patients in 2005. And generally it occurs in patients at a younger age group than we typically see in our cirrhosis patients. The cumulative incidence at 10, 20, and 30 years is about 0.8, 2.9, and 13.3%, which is far greater than this same population, the general population of the same age group. What's interesting is only about 50% of these patients have cirrhosis at the time of diagnosis of HCC, and 40% have advanced HCC at the time of diagnosis. So, the presence of cirrhosis doesn't necessarily have to be present in order for these patients to be diagnosed with HCC or to develop an HCC. In this multicenter case series aimed at identifying the outcomes and mortality risk factors for patients that develop HCC, they had 33 biopsy-proven cases. The median age was 30, so a very young patient population, and their median age years since Fontan was 22 years. And the most common type of Fontan connection was an atriopulmonary connection. And there are a few studies that do suggest that the older connection has been more associated with the development of HCC. And we're only now starting to see the adults of the patients that had the classic connection. So it will be interesting over the coming years to see if we see a change in the epidemiology of HCC with, the extracardiac Fontan being the more common performed surgery now. 52% had underlying cirrhosis, and the cumulative survival was 50% at 12 months. But what you can see here is that there was a significant difference between the patients that were asymptomatic at time of diagnosis versus those who were symptomatic. So that brings us to the idea of, these patients should be screened so we can identify them early and improve survival. The predictors of HCC development generally are patients that have poor cardiac function. So patients that have had to have valve repairs, they have a higher cardiac burden of comorbidities like arrhythmias, heart failure. They've required prior Fontan revisions. They have higher New York Heart Association class, higher CVP, atrioventricular regurgitation, and then lymphatic disorders as well. So generally a sicker population from a cardiac standpoint. We do know that with time, there's an increased cumulative incidence of HCC. We also know that from our cirrhosis patients, an incidence of 1.5% per year or greater justifies screening. There is one prospective study looking at HCC diagnosis in Fontan, in this patient population, Fontan patients, and they report about a 1.3% per year cumulative incidence. So, close enough to the 1.5% mark. And then when you take into consideration that these patients are far younger than our typical cirrhosis patients, it definitely supports the idea that we should be screening these patients. So generally, the recommendation based on the most recent EASL position paper on Fontan-associated liver disease is that we start around 10 years. There are very few reports of patients that have been diagnosed less than 10 years since the time of their Fontan, but they're, a case, I think 1 to 2 cases of that. Generally speaking, it's exceedingly rare to develop an HCC before the 10-year mark, failing Fontan circulation, portal hypertension. So these are all things that we need to consider as a whole. So even if a patient is earlier than that 10-year mark, if they have features of poor cardiac function, we should consider screening them for HCC. Of course, if they have higher serologic fibrosis scores, a MELD without INR, or higher AFP, these are all patients that we want to consider screening earlier if we feel like it's necessary. And with regards to AFP, of course, it is a very important biomarker in our patients with cirrhosis. But what's interesting is that there were a couple of studies looking at AFP in this patient population. They found that the AFP was above the upper limit of normal in up to 80% of patients with HCC, which is higher than the non-Fontan population. In addition to that, another large cohort study reported the likelihood of HCC was 26 times higher in patients that had an AFP above 10 or greater. And in that same study, the median AFP was lower in patients without HCC. And one of the thoughts here is that this is not primarily an inflammatory condition. When we think of things like Hep C, when we think of alcohol, there's a lot of inflammation going on in the liver, which may raise the AFP. But in this population, yes, there is some inflammation, but that's not the primary problem. So that presence of an elevated AFP may be a little more alarming in this population than you would, then I guess if you compare it to a patient with an underlying inflammatory process. And then recommendations for screening. So generally speaking, at the 10-year mark or earlier, if you feel it's necessary for your patient, the recommendation by EASL is to get an abdominal ultrasound and ACT or MRI and an AFP as a baseline study so that there's something to compare to when you continue screening these patients. But then once you have those baseline studies, to perform an ultrasound and AFP every 6 months with ACT or MRI every 1 to 2 years. In the absence of a nodule, that can continue. But if a patient develops a nodule, it depends on whether there's typical or atypical features. If it's typical for a benign lesion, then they can continue on that regular ultrasound and AFP with occasional cross-sectional imaging versus biopsy if a patient develops a lesion that is concerning for malignancy. And then there was one abstract that was presented as a poster at the liver meeting, and that was looking at the utility of contrast-enhanced ultrasound in HCC surveillance in Fontan patients. It was a small retrospective study of about 10 patients, and they had them undergo contrast-enhanced ultrasound and standard ultrasound. They also had prior CT or MRI data to compare to see if the patients had previously had lesions. And they correctly classified 8 out of the 10 lesions as benign. One was they weren't able to localize one lesion on the contrast and ultrasound, and the last patient had incomplete characterization. They didn't clarify further what they meant by that, but basically 8 out of that 10 had correct characterization. So it is definitely something to think about. You know, we do have patients that may have renal disease, they may have a contraindication to MRI. So it's not, it is possible that we may have a patient that can't undergo cross-sectional imaging. So this may be a good option as well when thinking about screening these patients. So my key takeaways is that hepatic congestion, abnormal blood flow are predisposing factors to develop nodules in this patient population. We can see a wide variety of nodules. Screening should begin at 10 years, but we need to think about it sooner if the patient, you know, has higher risk features, and a combined imaging approach may be best to help identify lesions. This part of Fontan, there's a ton of room for research. I think especially with things like GALAD and AFP-L3 becoming, you know, a point of research for our patients with cirrhosis, I think it'd be very interesting to look at. And there aren't any papers published on that data. So I think it's ripe for the picking. Thank you.